I am demonstrating partial knee replacement surgery using MAKO Robotic system. Here is the patient of 52-year-old female, comes with medial knee pain, and X-ray confirms that medial osteoarthritis is seen. This pain is there from last 5 years, and the knee wear and tear is only seen in the inner part of the knee. After we mount the pins and trackers, we will then take the data. So hip center is recorded, medial malleolus, lateral malleolus is recorded. Then comes multiple points to cross check in the medial femoral condyle. All areas of medial femoral condyle, including the notch, anterior part, medial epicondyle, posterior medial aspect, and all the areas of medial femoral condyle points are taken. Unlike in a total knee, here we will be taking only medial part of the knee. Likewise, we are taking multiple points from proximal medial tibia, and we will cross check these points and to assess if we have taken it properly or not. The error it should be very minimum. Now we are bursting the blue bigger dots. Then comes the gap assessment. You can see here medially there is a less space. We have to check with the varus thrust, valgus thrust, that is inner part, inside movement and outside movement, and then we have to assess this in multiple range of moment: 0 degrees, 20 degrees, 45 degrees, 90 degrees, 120 degrees. Like that, we have to take in multiple angles. The space opening and space of the knee should be taken in multiple flexion range of movements. And then consolidated values of each gap in flexion and extension is shown in this graph. For example, in this graph, it is showing at extension medially how much is loose, in the flexion 45 degree, 90 degree, 120 degree, how much flexion is loose and extension is loose. Like that, values are shown in the graph. Then comes the sizing, that is simulating this implant size and overlap of the femoral and tibial component is now depicted in this graph. So we have to make sure that the femoral component in all throughout or maximum throughout the range of movement is in contact with the tibial component. That is the first point. Second thing, femoral component is not overhanging the femoral bone. And third point is femoral component is not outside the cartilage border. And the slope of the tibia, femoral component flexion, femoral component orientation, and inflection of the knee, the femoral component should be in the middle of the tibial component. You can see in this here green, blue, and green. That means that at the flexion, at the extension, all throughout the range of movements, this femoral component, when knee is loaded, is in the middle of the tibial. That means both components are uniformly loaded when person is flexing and extending and walking. This is the last thing, which is the cartilage mapping. So we have to check if the cartilage and at the tibia here, that in the extension, how much of this is in coming in contact with the ACL and tibial spine and overlapping the cartilage. These minute details are also recorded. In fact, this MAKO system was introduced with the partial knee replacement, and this procedure is very much accurate and pretty much takes the detailed values of everything in all throughout the range of movements, and then comes only after that the resection of the bone. Here we are doing the tibial resection here. This is controlled by the haptic boundary. Tibial resection, the transverse resection of the tibial plateau bone is done with the saw, and the vertical thing we sometimes used to do for partial knee reciprocating saw. Here we can use the burr instead of reciprocating saw. And for the femoral bone resection, it is completely done by burr, and we have to remove those green colored areas, then confirms the femoral component, femoral bone preparation. You can see here how nicely femoral bone is removed. And then also lug holes, we have to overlap the burr on the lug hole marking, and then the lug hole is now made. This is the vertical cut of the tibia, that is we used to do initially with the reciprocating saw. That was the same thing I'm telling. Here we are doing with the burr. Once these things are confirmed, then comes the implantation. Implantation is like implanting the total knee replacement. This is the trial. We can trial it again, and we will assess the balance in the trial implant. Once we are completely satisfied with the balancing, then we goes to the confirmed implantation. This is the final implantation, and we are very satisfied with this type of procedure. Patient will be very happy. Thank you for watching this video.